طبعا أنا اليوم today I'm going to talk about benign and malignant gastric conditions. On Tuesday, I will also talk further about more gastric tumors and small bowel tumors. But the content of my presentation today will be first on peptic ulcer disease, which is the most important and the commonest benign gastric condition that is seen by surgeons and gastroenterologists. And the second part of the presentation will be on gastric adenocarcinoma and lymphoma. On Tuesday, I will talk about GIST tumors as well as small bowel tumors. So this is a historic quote from a very ancient English book. It says that the stomach has the liver below it like a fire underneath a cauldron. Cauldron is like a jidr, مثل a big pan. And thus the stomach is like a kettle of food. The gallbladder is its cook and the liver is the fire. طبعا, at first glance, you might think that this is a very crude presentation or false presentation. But if you think about it deeply, it's kind of, there is some logic to it. I mean, the liver is truly the fire of, with all the enzymes that it's producing to digest and cook the food. طبعا المقولة مو صحيحة ولكن فيها بعض الغرابة وممكن الشخص يلقى فيها بعض الفلسفة التي قد تنطبق في هذه الأيام. طبعا تشوفون شكل المعدة والكبد والمرارة. طبعا المرارة is not the cook. Now, if we talk about peptic ulcer disease, peptic ulcer disease is caused by peptic ulcers, which are focal defects in the gastric or proximal duodenal mucosa, and it can extend down to the submucosa. يعني لما الinjury extends to the submucosa or deeper caused by the acid, this is called a peptic ulcer. It's not only an injury to the mucosa, it's an injury that extends to the submucosa. It can also happen, يعني peptic ulcers, they don't happen only in the stomach and the proximal duodenum. في مكانين ثانيين, two other places where the peptic ulcers can occur, في Michel's diverticulum and also in the distal esophagus. طبعا الباثوفيزيولوجي عبارة عن خلل في الديفنس and repair, and it's ultimately caused by an imbalance between the action of peptic acid and the mucosal defenses. Surgery is historic now, but it's important to talk and mention the surgical procedures performed in the past for benign peptic ulcer diseases. ليش? Because many disciplines, in particular bariatric surgery discipline, emerged from surgery for peptic ulcer diseases, and also some of the surgeries for peptic ulcer disease are similar to the surgeries performed for malignant gastric disease, and you still at times require to do surgery for emergency treatment of complications of peptic ulcer disease. Why did peptic ulcer disease surgery become almost historic in the past? خلينا نقول في end of 70s, beginning of 80s. General surgeons, when they are on call, they will perform mostly gastric surgeries. But the discovery of H. pylori, along with the advent of endoscopy and proton pump inhibitors, changed the game completely. الثلاث أمور, these three things, H. pylori discovery, proton pump inhibitor discovery, endoscopy creation, changed the way we deal and operate with peptic ulcer disease. But surgery is still utilized in specific situations. طبعا قصة ال H. pylori قصة مشهورة. H. pylori bacteria is a major risk for peptic ulcer disease. It also increases the risk of gastric adenocarcinoma and gastric lymphoma. الاثنين على اليسار واحد فيهم is a pathologist from Australia and the other one is a internist, and both discovered H. pylori in the mid 80s. The internist there was only a registrar at that time when he discovered it, and he was awarded the Nobel Prize in Medicine in 2005. It's important to eradicate H. pylori if you have a patient with symptoms related to H. pylori. The diagnosis is usually via endoscopic enteral biopsy or via urease test. You can do histology, culture, or PCR. التريتمنت عبارة عن البروتون pump inhibitor for 1 month along with 2 antibiotics for 7 to 14 days. It's called the triple therapy. The antibiotics usually are clarithromycin and omeprazole, or clarithromycin with amoxicillin. The eradication should be confirmed after the completion of treatment. طبعا first offender السبب الأول للبيبتيك ulcer disease هو H. pylori. The second cause will be NSAIDs, non-steroidal anti-inflammatory drugs. The ingestion of NSAIDs is the second commonest cause of peptic ulcer disease. The risk of complications increases with age older than 60 and patients having a prior GI event, or patients who are using steroids and anticoagulation. طبعا the medical treatment of peptic ulcer disease is easy. It's proton pump inhibitors with the eradication of H. pylori if H. pylori is positive. Peptic ulcer disease in the stomach, ulcers in the stomach, 70% of them are associated with H. pylori. In the proximal duodenum, about 90 to 95% of duodenal ulcers are associated with H. pylori. And then, how do peptic ulcer disease present? The commonest cause of the commonest symptom at presentation usually is abdominal pain. It's not reflux. GERD ما له علاقة بالH. pylori ولا له علاقة بالpeptic ulcer disease. الحارج، الارتجاع، عسر الهضم اللي هو ارتجاع الأحماض ما له علاقة بالH. pylori. The pain is usually epigastric, well localized, relieved by food if it's a duodenal ulcer, and worsened by food if it's a gastric ulcer. So usually patients with duodenal ulcer will be more obese. Those with gastric ulcer will lose weight. The pain might radiate to the back, and it might be brought on by emotional stress. ولكن emotional stress is not a cause of peptic ulcer disease. Before the discovery of H. pylori, we used to think إن الستريس لا علاقة بالبيبتيك ulcer disease، وهناك قصص بشأن ذلك. مثلا كانوا سابقا يجدون أن في عوائل معينة، and this is an interesting story يمكن ما له علاقة بالجراحة، يجدون أن في عوائل معينة تجد في العائلة أن غالبا متوترين، عصبيين، وعندهم قرحة. فالاعتقاد أن هذه العائلة بسبب عصبيتها ووراثتهم للعصبية تسببت لديهم العصبية أو النفسية بالقرحة. ولكن عقب ما اكتشفنا الاتش بايلوري، شنو اكتشفنا؟ أن أغلب العوائل تصاب كلها بالاتش بايلوري، يعني الأم، الأبو، الإخوان، الأبناء كلهم فيهم اتش بايلوري بسبب they are sharing the same food and the same water. فبالتالي السبب ان العائله كلها عندها القرحه لان كلهم شربوا او تم اصابتهم بالاتش بايلوري، وما له علاقه بالنفسيه او بهذه الامور الاخرى. طبعا now I'm going to talk about emergency procedures. أو متى الجراح, when is the surgeon going to be called in the year 2020 to operate in patients with peptic ulcer disease? You can see in this X-ray الرئة طبعا سوداء واضحة، بعدين خط أبيض، تحت الخط الأبيض في خط أسود. All right, good. So you can see here that, so when is the surgeon going to be called to operate in peptic ulcer disease? in the year 2020. Now, I'm going to focus on the surgical treatment for complications of peptic ulcer disease. You can see in this chest x-ray, I mean, the lung is clear, it's black, the air is black, and then there is a fine sliver of, there is a white color there with my pointer. White line separating the lung air from an air below it. And likewise, on the left side, you can see also that white line separating the air in the lung from a black area here, which is air. So this is called air under the diaphragm. This chest x-ray is the commonest x-ray that you will see in surgical exams. An x-ray showing air under the diaphragm. So when you have a patient with an acute abdomen and air under the diaphragm, this is a sign of a perforated viscus. And a presentation of a perforated duodenal ulcer, patients with perforated duodenal ulcer, they will present with acute abdomen, board-like rigidity in examination, tachycardia, hypotension, fever, high white count. You will do a chest x-ray and you will find this in the chest x-ray, air under the diaphragm. That's a perforated duodenal ulcer. So what are the presentation of peptic ulcer disease? Pain, perforation, perforated gastric ulcer or a perforated duodenal ulcer, bleeding gastric ulcer or a bleeding duodenal ulcer, and obstruction. And the obstruction will usually happen at the prepyloric region. It is called a gastric outlet obstruction, and it will be manifested by a delayed gastric emptying, anorexia, or nausea accompanied by vomiting. So perforation, bleeding, obstruction. You will operate in those three complications of peptic ulcer disease. In terms of a perforated duodenal ulcer, your management. So first you will see that air under the diaphragm, along with the signs on examination. Your management will be first to stabilize the patient. So you'll stabilize the patient with IV fluids, IV antibiotics, and IV proton pump inhibitor infusion. You will consult the intensive care unit if the patient is sick, and then you will take the patient to the operating room. We usually utilize laparoscopic exploration for patients with perforated duodenal ulcer, but you will not be faulted if you say that you'll go for a laparotomy. I would say in your exams, in the oral exams, to show that you are a safe surgeon, you can say that you'll take the patient for a laparotomy. It would be my first answer, but I would say as well that we can also perform laparoscopy, but since I haven't done that much laparoscopy, I'm going to take the patient for a laparotomy. At laparotomy, you will wash as much as you can. Maybe you might use 5 or 6 liters of fluid to wash the abdomen, and then you will do a Graham patch repair. And the Graham patch repair is very simple. You will take a tongue of the omentum and you will patch the area in the duodenum, the perforation, with the piece of omentum, and you will suture around it. You wash as much as you can, and then you will put drains, 2 or 3 drains. Don't be stingy with the drains. Put as much drains as you can because drainage of this is important. You'll also put an NG tube, post-operatively NG tube and a Foley catheter. Post-operatively, you will continue the IV antibiotics, and you will do an H pylori eradication, because as I mentioned at the beginning, 95% of patients with duodenal ulcers will have H pylori infection. So a perforated duodenal ulcer, Graham patch repair. In terms of bleeding duodenal ulcer, you will do a pyloromyotomy and suture repair of the bleeding vessel, and then with a pyloroplasty. Now, what is a pyloromyotomy? Simply, pyloromyotomy means opening the gastroduodenal junction, and you will open it transversely. You will open there and you will see the bleeding, and then you will suture the bleeding at 12 o'clock and at 6 o'clock. The bleeding, the picture in the operating room will not be like this. You are not going to see the vessel. You just need to imagine the vessel, which is the gastroduodenal artery, and then you will suture that vessel or the area of bleeding at 12 and at 6 o'clock. If you do that, This is a favorite exam question. They will ask you, you did a pyloromyotomy, you did a suture repair, you put a suture at 6 o'clock, you put a suture at 12 o'clock, and there is still bleeding. You would say that you do another suture, a U-stitch. It's called a U-stitch at 3 o'clock, because sometimes you'll have a transverse vessel there that you will need to suture. After that, you will close your pyloromyotomy in a pyloroplasty fashion so that you don't narrow the area. So for a bleeding duodenal ulcer, you do a pyloromyotomy, suture repair of the bleeding vessel, and a pyloroplasty. Very simple. You can do that open, of course, unless you have advanced laparoscopic skills. You wouldn't say in the exam that you'd go laparoscopically for that. Now, some papers might utilize angiography and embolization. طبعا, there is a very important point. You would do a gastroscopy first in bleeding. You are not going to go right away for an operative approach. You will stabilize the patient, correct the coagulation, make sure they don't have a liver disease, wash the stomach with an E-wall tube, then you will do a gastroscopy. At gastroscopy, they will try to control the bleeding endoscopically. If they cannot control it the first time, you will go a second time with endoscopy. If the second endoscopist cannot control the bleeding, then you would go for surgery. This is the same with a bleeding gastric ulcer. It is simpler to deal with the bleeding gastric ulcer because you are not going to get narrowing when you do a pyloromyotomy and a pyloroplasty. You will just open the stomach, do a gastrostomy, find the bleeding vessel, suture, repair it. That's, of course, after you fail endoscopy. Endoscopy is your first approach, and you will do it twice. If 2 endoscopies fail and the patient continue to bleed, then you are going to go for surgery, either in a bleeding gastric ulcer or a bleeding duodenal ulcer. The third situation where you need to operate in a peptic ulcer disease will be the gastric outlet obstruction. This is a case I have done recently in a patient with a gastric outlet obstruction. You can see how narrow is the area there at the gastroduodenal junction. This is very narrow and fibrotic. Patients would usually present with gastric distension, repeated vomiting. You would do a chest X-ray, and you will find that the patient's stomach is huge and dilated. You would do an endoscopy, and at endoscopy, the endoscopist will tell you that they cannot pass the pylorus. Usually, your first approach will be to put an NG tube. You would feed the patient. If you can bypass the obstruction with a Doboff tube, it's fine. If you can't, then you will decompress the stomach and feed the patient maybe by TPN first, and start the treatment for this patient as if you are treating a peptic ulcer disease. So you would give H. pylori eradication. You would give PPI therapy and infusion for 3 days, and then you continue the maximum therapy with the H. pylori eradication. And you can give the patient up to 4 to 6 weeks. So you treat the patient conservatively for 4 to 6 weeks, repeat the endoscopy. If still the endoscopist cannot pass the area, then after 4 to 6 weeks, despite maximal therapy, then you will go and take the patient to the operating room and perform a resection. Usually, if you are sure that this is a benign disease, you can do a bypass, but I would preferably do a distal gastrectomy because you might never know. It could be cancer causing this. So, in summary, surgical intervention is still required in 8 to 20% of patients developing complications from peptic ulcer disease. The surgical therapy will serve several purposes. It will salvage the patient from life-threatening complications, mainly perforation, hemorrhage, and gastric outlet obstruction. And it can provide cure for the disease in the form of protection from recurrence. But we know that medical therapy and H. pylori eradication can prevent recurrence. So we don't perform major procedures in those patients. to prevent recurrence these days. I'm going now to talk about the historic surgeries performed for peptic ulcer disease. It's important to understand these surgeries. So, in the past, they didn't have proton pump inhibitors to reduce acidity. So, what would they do to reduce acidity of the stomach and prevent peptic ulcer disease? They will do a vagotomy and distal gastrectomy. When they do a distal gastrectomy, they will remove the antrum, which is the source of acid secretion, right? So if you don't have PPI in the 70s, what would you would remove the antrum and you would do a vagotomy to reduce the acid secretion, right? These two surgeries, nowadays, if you read about peptic ulcer disease, you will come across vagotomy, distal gastrectomy, Billroth 1, Billroth 2, highly selective vagotomy. These are of historical importance. You will not perform them these days for peptic ulcer disease because H. pylori eradication and proton pump inhibitor replaced and killed those surgeries. I did vagotomy very rarely recently for a patient with marginal ulcer post-bariatric surgery, but I have never needed to do a vagotomy for peptic ulcer disease. Now, it's important as well, and whenever you read about peptic ulcer disease, you will come across types of peptic ulcer. Types of peptic ulcer these days do not change the management much, but in the past, when they did not have PPI, it was important to know what type of peptic ulcer it is. Why? I'm going to tell you why. Because, first of all, there are 4 types of peptic ulcers. There is type 1, which is at the junction, at the lesser curvature, at the junction between the fundic and the antral region. Type 1 and type 4, which is a high ulcer, these 2 types are not associated with acid secretion. So in the 70s, if you are going to operate and you find out that the ulcers are either type 1 or type 4, you will not be very aggressive in performing procedures that are going to reduce the acid because you know that these 2 types are not caused by acids. But type 2 and type 3, which consists of a pre-pyloric ulcer and a duodenal ulcer, these are caused by high acid secretion. So it's important to do maximum acid inhibition in terms of the surgery. In the left there, these are the areas of the stomach. It's important to know the areas of the stomach, okay? For anatomical purposes, for any operation in the stomach. So you have the lesser curvature, you have the greater curvature. On top there, you have the fundus. This is the very important part that you remove during sleeve surgery. You have the esophagus. The cardia is the first few centimeters in the stomach near the esophagus. Fundus, body, antrum, pre-pyloric region, pylorus, and the duodenum. These are the areas of the stomach. This is the anatomy of the stomach. It's important to know. Again, this is another diagram showing different types of ulcers. Again, this is not very relevant nowadays. It is academic and historic. It's not going to change your management much. Why? Because we have proton pump inhibitors, because we understand that the role of H. pylori in the formation of peptic ulcers. Now, this is a highly selective vagotomy. You'll come across that often. We don't need to perform these surgeries these days because we have PPI and H. pylori eradication. This is distal gastrectomy with Billroth 1. So what is distal gastrectomy with Billroth 1? Billroth was a famous Austrian surgeon who trained most of the famous surgeons in the beginning of last century and the end of the 19th century. So whenever he did the first gastrectomy ever, and he performed many different first procedures. His students also were surgeons who performed some of the first procedures ever surgically. And in Billroth 1, it's a reconstruction. So if you do a distal gastrectomy, you're going to remove the antrum. You remove the antrum without touching the left gastroepiploic artery. Okay, so if you cut the left gastroepiploic artery, the right gastric artery, the right gastropiploic, this is called a subtotal gastrectomy. But if you only cut the right gastric artery and the last right gastropiploic, this is called a distal gastrectomy. So you're going to cut the stomach. How you are going to reconnect the stomach to the duodenum? If you do end-to-end, like that, this is called a Billroth 1 anastomosis. It's basically a gastroduodenal anastomosis. It is not recommended because of marginal ulcers and remnant cancer. And the preferred method of reconstruction nowadays is a distal gastrectomy with Billroth 2. What is a Billroth 2? It's a gastrojejunectomy. It's an end to side gastrojejunectomy. So end of the stomach to the side of a loop of jejunum. This is a Billroth 2. It's a reconstruction. The reconstruction is with Billroth 2, but it's the same area resected. You can see there that there is a vagotomy performed as well. Now, so I'm going to end now the talk on peptic ulcer disease, and then we'll move on with gastric adenocarcinoma and gastric lymphoma. So in summary, commoner surgeries performed today for peptic ulcer disease are Graham patch and ligation of bleeding vessels. The use of PPI and treatment of H. pylori made us very rarely perform distal gastrectomy and vagotomy. This is basically the summary of peptic ulcer disease. I'm going to move on now to gastric adenocarcinoma. So tumors of the stomach, you have GIST, you have polyps, you have adenocarcinoma and lymphoma. I'm going to leave the GIST tumors for the talk on Tuesday on small bowel cancers. In terms of the gastric polyps, there are 5 types of gastric polyps: inflammatory, hamartomatous, heterotopic, hyperplastic, and adenomatous. Hyperplastic are common and they are not precancerous. Stomach adenocarcinoma. 95% of gastric cancers are adenocarcinomas. And gastric tumors are classified according to their site in the stomach. So either proximal tumors or distal tumors, because the surgery performed for these tumors are different depending on the anatomy. In the proximal gastric unit, you would usually perform a total gastrectomy, you remove the whole stomach. In the distal gastric unit, you will do a distal gastrectomy or a subtotal gastrectomy. These are the 3 surgeries performed for stomach cancer. Total gastrectomy, you remove the whole stomach. Distal gastrectomy, you remove the antrum. Subtotal gastrectomy, you are going to remove about 80% of the stomach. You will only leave the stomach with the left gastric artery and the short gastrics. Then, what are the risk factors? The risk factors include H. pylori, pernicious anemia, atrophic gastritis. PJ syndrome and Li-Fraumeni syndrome can cause an increased risk of gastric cancer, also BRCA2 and HNPCC. Diets rich in salt, smoked or poorly preserved foods, nitrates, they are all risk factors for gastric cancer. So before the invention of the fridge, food usually was salted or smoked, and H. pylori was not discovered. So gastric cancer at the beginning of the last century was one of the commonest cancers worldwide. And the invention of fridge, discovery of H. pylori, changed the map of gastric cancer all over the world. The most common genetic abnormality in sporadic gastric cancer affect the P53 and COX2 genes. Recently, a germline mutation in CDH1 gene encoding for E-cadherin was shown to be associated with hereditary diffuse gastric cancer. Gastric tumors are broadly categorized into 2 types, intestinal and diffuse. The intestinal type arises from the gastric mucosa. It's associated with older patients and distal tumors. The diffuse type is believed to originate from the lamina propria of the stomach and grows in an infiltrative submucosal pattern. The diffuse type is associated with younger patients and proximal tumors. In terms of the clinical presentation, weight loss is the commonest clinical presentation. Remember when we talked about peptic ulcer disease, gastric ulcers, it can be malignant or benign, cause pain when a patient is eating. So usually they will not eat because eating will precipitate and bring on the pain. So weight loss, abdominal pain, nausea, anorexia, dysphagia if the tumor is proximal, or repeated nausea and vomiting if the tumor is distal. So if the tumor is proximal near the G junction, there will be obstruction. If the tumor is distal near the pylorus, also it can cause gastric outlet obstruction. The gastric pain is made worsened by food. Sorry, this is a mistake there. It should be, it's made worse with food, not relieved by food. And the dysphagia is usually associated with tumors of the cardia of the junction. Enteral tumors, as I mentioned before, can cause gastric outlet obstruction. These are favorite exam questions for medical students, signs on examination. We don't see them nowadays. Palpable, rarely. I mean, you can see sometimes the palpable supraclavicular lymph node, which is called the Virchow node. A mass palpable in the rectal examination called Blummer shelf. A palpable periumbilical mass, Sister Mary Joseph node. In terms of the initial evaluation, of course, you'll do a complete history and physical examination. You'll do routine lab studies. After that, you'll perform the upper endoscopy if you have suspicion. The upper endoscopy is important for diagnosis and to take a biopsy for pathology sampling. You'd also, for staging, do a CT, chest, abdomen, and pelvis. EUS nowadays is essential. It's important. You have to mention that in your exam. Endoscopic ultrasound preoperatively is important, as well as PET scan. Diagnostic laparoscopy is not a must, but you would utilize it if you have a high suspicion of peritoneal disease. But you have to perform endoscopy with EUS, a CT, and PET scan. In terms of the EUS, 20 to 30% of patients who have disease that is beyond T1 stage on EUS will be found to have peritoneal metastasis despite having a negative CT scan. Also, EUS is important because you will give neoadjuvant chemotherapy if the patient is not N0 and if the patient is having a disease more than T2. I'm going to talk about that later and explain it further. So this is the staging. T1, tumor extending to the submucosa. T2 to the muscularis propria. T3 to the serosa. T4 to other structures. If you have any tumor at EUS extending beyond T2, then you are going to give neoadjuvant chemotherapy. If you have any suspicion of lymph node involvement at the EUS, preoperatively, you need to give neoadjuvant chemotherapy. You give chemotherapy before the operation itself because it is associated with better survival. In terms of the lymph node status, if you have 1 to 2 positive lymph nodes, that's an N1. N2 is 3 to 6 positive lymph nodes, and N3 is 7 or more positive lymph nodes. So what is the management? Now, you have a patient with malignant gastric ulcer, you took a biopsy, it's gastric adenocarcinoma, you did the US, PET scan. In the management, you are going to assess the resectability, give neoadjuvant therapy in the terms of FLOT regimen, and then you will perform the surgery. What is the extent of the resection? In terms of the extent of the resection, there is no difference between total and subtotal gastrectomy if you can achieve an R0 resection. If you can remove the whole tumor, you don't need to remove the whole stomach. It is better to leave some stomach because the quality of life will be much better. And you need to take 6 centimeters a margin above and below the tumor. It's important to do that because of the potential of submucosal spread of the tumor. These are the surgeries performed. So This is a subtotal gastrectomy with a Billroth 2 reconstruction. So you will have a proximal gastric unit along with a side of jejunum, so end to side, or a total gastrectomy. In the total gastrectomy, you will do a Roux-en-Y reconstruction. You will not do a loop jejunum reconstruction. Why you wouldn't do a loop? Because you will have an increased risk of bile reflux. So if you remove the whole stomach, you'll do an esophagojejunostomy in a Roux-en-Y configuration, and you'll do another jejunostomy there to divert bile. Again, this is another slide of operations performed for stomach cancer. So you either do a subtotal gastrectomy with gastrojejunostomy, a distal gastrectomy with gastrojejunostomy, or a total gastrectomy with a Roux-en-Y configuration. If the tumor is very distal, you can get 6 centimeters above the tumor without taking the left gastroepiploic, then you will do a distal gastrectomy. If the tumor is in the body, you need to go up to 6 centimeters to get a negative margin, then you'll do a subtotal gastrectomy. If the tumor is in the cardia, then you might do a total gastrectomy. In terms of the complications, you'll have leak, bleeding, duodenal stump blowout, PE, and bile reflux. Duodenal stump blowout is a very important complication because it's easy to miss and not recognize. And basically, you see that area of the duodenum that you leave after the resection. That area can leak out. And if it leaks out, it's going to leak out bile and pancreatic juice. Very bad and lethal complication because it's hard to detect. You'll do your upper GI swallow. Let's say you have a sick patient postoperatively. You'll do the upper GI swallow. You find no leak because the anastomosis is there. So you think the patient is fine, but basically he's having a worse leak in that area. So you need to have a very high index of suspicion to detect and discover duodenal blowout leaks because prompt management is very important in these patients. Now, what about GE junction tumor? Tumors of the GE junction have been further divided according to the Seward classification. It's also referred to as adenocarcinoma of the esophageal junction. The operation can be different there. Sometimes it can require an esophagectomy, not only a total gastrectomy. And in terms of the Seward classification, they are further divided into 3 types of tumors. You have the type 1 Seward, which is tumors associated with Barrett's esophagus, and they are true esophageal cancer growing. So it's from the esophagus growing into the GE junction. They require an esophagectomy. Type 2 cancers are junctional tumors. They are truly lying within 2 centimeters of the squamo-columnar junction at the level of the cardia. They might need also an esophagectomy. Type 3 cancers are present within the subcardial region of the stomach, and you can perform total gastrectomy for those cancers. So, type 1 Seward, you will do an esophagectomy. The optimal surgical management of type 2 and type 3 cancers is controversial, but the incidence of lower mediastinal lymph node metastasis is high, 10 to 40%. So you should consider an esophagectomy. Thoracotomy used to be a debate of whether to perform a thoracotomy to get an adequate lymph node dissection in that area. But now thoracotomy is considered important to get adequate lymph node dissection. Some authors, there is some resurgence of in the literature of surgeons recommending proximal subtotal gastrectomy. So maybe for Seward 3, instead of doing a total gastrectomy, you can do a proximal resection of the stomach, and then you would anastomose the esophagus to the distal gastric unit. This was not the preferred method in the past because of high incidence of ulcers and bile reflux, and gastroparesis. But some surgeons are performing that now, and some are reporting good results. But for our sake, we say that there are 3 operations for gastric tumors: total gastrectomy, distal gastrectomy, subtotal gastrectomy. If it's a Siewert 1 or 2, you might also perform an esophagectomy. In terms of the extent of lymphadenectomy, it used to be a matter of debate, but now D2 should be the standard of care. The draining lymph nodes basin of the stomach have been meticulously divided into 16 stations, as you can see here, by Japanese surgeons. Station 1 to 6 are perigastric, and the remaining 10 are located adjacent to major vessels behind the pancreas and along the aorta. D1 lymphadenectomy basically refers to the limited dissection of only the perigastric lymph nodes. D2 dissection is an extended lymph node dissection, entailing removal of the nodes along the hepatic, left gastric, celiac, and splenic arteries, as well as lymph nodes around the splenic hilum. D3 dissection is an extended lymphadenectomy. Some Japanese surgeons used to perform that in the past, and it is used to describe a D2 dissection plus the removal of the nodes within the porta hepatis and the peri-aortic regions. The recommended approach now and the standard of care is performing a D2 lymphadenectomy. The research is conflicting. The randomized controlled trials are conflicting between D1 and D2, but in many centers, D2 is now the standard of care. In terms of the chemotherapy, we started with the McDonald protocol, which is adjuvant chemotherapy. You go in, do your resection, then post-operatively, you will give a 5-FU with leucovorin plus radiation therapy. This used to be the standard of care in many centers in the United States. Adjuvant chemotherapy, post-operative chemotherapy with radiotherapy, the McDonald protocol. And then came along the MAGIC trial, which used epirubicin, cisplatin, and 5-FU. They used to give 3 cycles. So you have leucovorin, epirubicin, cisplatin, 5-FU, 3 cycles preoperatively, neoadjuvant, and then 3 cycles postoperatively. In the US, if you have lymph nodes positivity or you have a tumor above T2, you would give MAGIC protocol. 3 cycles pre-op, 3 cycles post-op. But currently, we have the FLOT trial, which was published in 2019. It is now the standard of care in many centers. If you look at the NCCN, you still have the MAGIC protocol and the FLOT protocol, but in many centers, they are using the FLOT protocol as the neoadjuvant chemotherapy protocol for patients with gastric adenocarcinoma. And basically, they will give 4 cycles of fluorouracil plus leucovorin, oxaliplatin, and docetaxel preoperatively, and 4 cycles postoperatively. If D2 is not performed, then you will add radiotherapy postoperatively. So neoadjuvant chemotherapy in the form of FLOT is the standard of care for gastric adenocarcinoma. This is an important update. Now, I'm going to move on to the last 3 slides and we'll be done talking about gastric lymphoma. The stomach is the most common site of lymphoma in the GI system. Over 95% of gastric lymphoma is of the non-Hodgkin's type, and it consists of 4% of all gastric malignancies. It can be divided. There's also the low-grade MALT lymphoma. It's a different type of lymphoma. Low-grade MALT lymphoma is basically a monoclonal proliferation of B cells. It arises from a background of chronic gastritis associated with H. pylori. What you do for low-grade MALT lymphoma is you eradicate H. pylori. If you do H. pylori eradication, the low-grade MALT lymphoma will disappear, but you need to have also a careful follow-up. If low-grade lymphoma persists after H. pylori eradication, you might consider radiation if the disease is confined to the stomach. High-grade lymphoma, this is the last slide. High-grade lymphoma, MALT lymphoma, they will have similar symptoms to gastric cancer patients. 50% will have systemic symptoms, such as fever, weight loss, and night sweats. It is diagnosed by endoscopy and biopsy. You need to do a diligent search for extragastric disease before the diagnosis of localized primary gastric lymphoma is made. So you'll do EUS, CT, maybe bone marrow biopsy. Most patients with high-grade gastric lymphoma are currently treated with chemotherapy and radiation without surgical resection. A very important point in your exams: whenever you are faced with a case of cancer, you have to mention tumor board. Discussion at tumor board is essential. This is the end of my talk. Thank you.
Doctor, we have some questions that have been sent throughout the webinar. First question was from Dr. Badr Shaban. He was
Yes.
asking, would your resection be any different if it was intestinal versus diffuse gastric cancer type?
I don't think it will change the management in terms of the resection, but usually it is thought with the diffuse gastric type, you will have a more aggressive disease, so you would want a more aggressive resection. But now the standard of care is aggressive. The standard of care is to perform a D2 lymphadenectomy. So I don't think it will change much that.
And there is another question from El-Maysa. How would you approach a patient when he has a duodenal ulcer and pyloric stenosis?
So if you have a patient with a duodenal ulcer and pyloric stenosis, you mean gastric outlet obstruction. They would usually, so if you have a pyloric stenosis, you are going to have a gastric outlet obstruction. You treat them first conservatively. You'll give H. pylori eradication. You'll give PPI infusion for 3 days, then maximum therapy of PPI. You would feed the patient by TPN, and if they open up, you will pass a drop-off tube feed. And then you will wait for 4 to 6 weeks. Then you will repeat the endoscopy. If the repeat endoscopy can pass, fine, the patient is cured. You will take biopsies, make sure there is no cancer. If the endoscopist still cannot pass the stenosis, then you need to perform a distal gastrectomy. You will also need to rule out gastrin-producing tumors from the pancreas.
Should we continue the questions, or do you want to start the MCQs first and then continue with the questions by the audience?
Let's start the MCQs first. We have 5 MCQs for you guys.
Okay. So we'll start with the first question. Everybody should be able to see it on their screen now. If you can.
You want me to ask the question?
Yeah. If you cannot see the question, please close the chat, and you should be able to start seeing it. Okay, you can read the question, doctor.
Yes, so 51 years old lady presents with vomiting of 24 hours duration and gastric distension and abdominal x-ray. Gastroscopy reveals an obstruction in the pyloric channel causing gastric outlet obstruction. Biopsies could not be taken. What is the next step in the management?
Most people answered answer D.
Good. So you got the right answer. So first, you have gastric outlet obstruction. You would first treat conservatively with proton pump inhibitors and H. pylori eradication. That's the right answer. Okay, next question.
Up now.
So 52 years old gentleman presents with third episode of upper GI bleeding while he was in PPI. At endoscopy, multiple gastric and duodenal ulcers are found. In reviewing his history, you find out that he had similar findings at previous scopes and was treated with H. pylori treatment in the past. So what would you do?
Okay, most people answered C.
Okay, it's a good answer. And because you have the patient treated for H. pylori, it's recurrent, this third time, he's not on NSAIDs, then you need to rule out gastrin-producing tumor in that situation. So let's go to the third question.
Okay. Should all be seeing the question right now?
Yeah. So 64 years old, heavy smoker complaining of severe abdominal pain, not relieved by narcotics, 2 days post distal gastrectomy. for malignant gastric obstruction. Upper GI swallow shows no anastomotic leak. The drain amylase is 7,000. Serum amylase is 120. What's the next step in the management?
Most people answered question
What's the answer? I cannot see it.
Most people answered question A. And
I cannot see the answers. Can you put them back for me?
oh, okay, sorry.
Yeah, so yes, you would do exploration, because this is most likely the scenario where there is a duodenal stump blowout. You will have drains in there, and the drain amylase will be very high, and the leak test will be negative in the barium swallow. So you need to go for exploration. That's how you diagnose usually a duodenal stump blowout. غالبا it's not going to be second day post-op, maybe third or fourth, but you can have it as early as second post-operative day. Next question. 30 years old Asian worker is complaining of severe abdominal pain. You diagnose perforated duodenal ulcer in the operating room. You cannot close the defect with an omental patch. What is your next step?
Most people answered C.
Yeah, so you can use a mushroom tube, close as much as possible of the defect around the mushroom tube, and drain the area widely. That's a simple way of doing this. If you want, you can add the pyloric exclusion if you can, but it depends on what you find and how extensive is the damage around the duodenum. Next.
Fifth question is up right now.
What is the preferred chemotherapy approach for resectable gastric cancer? Good, FLOT. So FLOT is the current approach, and the study was published in The Lancet in 2019. Good, ممتاز. What's next now, Ali?
We will just check the Q&A panel. We received a few questions.
I looked at the questions. Most of them are usually medical. There's one question about managing dumping syndrome. Dumping syndrome can happen after any gastric surgery, and you would manage it first by a nutrition consult. You would avoid caffeine, sugar, simple carbs. You'd avoid mixing food with liquid. That's the first approach to dumping syndrome. In terms of there is another question: will diagnostic laparoscopy pose risk of distant metastases if the peritoneal mets are present? If the peritoneal mets are present, then distant metastases wouldn't matter, because peritoneal mets are considered distant metastases. Okay, so I think these are the important questions to answer. Some questions are better suited for, some questions are more medical.
If anyone has any further question, you can type it in the chat now. If not, just would like to say thank you for this informative lecture. I personally learned a lot, and I'm sure many people did so. We'll be looking forward for your next lecture with you on surgical disease of the small bowel. That will be on this Wednesday.
We're going to talk about carcinoid, adenocarcinoma, and GIST. So GIST, adenocarcinoma, carcinoid on Tuesday, inshallah.
And since I don't see any further question, I understand I know you have precious time, and so we'll be concluding.
Thank you very much.
Thank you everybody for attending, and good luck.
تحياتي. مع السلامة. Thank you everybody.